Hi, good afternoon, everybody. Thank you for joining us today for our Want to Know More session on frailty. Thank you for waiting in the lobby. So I'm just going to go through a few housekeeping bits first of all, and then I can just see we've got some other people joining us who will be letting in. Thank you, welcome, thank you for joining. So today's session is on frailty. It should last about an hour, but we have got a little bit of time afterwards in case anybody has got any questions. We have the chat function open, so if you're able to use that and you've got any questions or comments or anything you'd like to share as our presenters are talking, then please do so. Just to let people know, the session today is being filmed, and that's so we can pop this on our Resource Centre YouTube channel afterwards. So if there's anything that you've missed, if there's anything you'd like to revisit, or if you'd like to share with colleagues, then please do so, and we can send the link afterwards. We've got quite a few presenters today, so I'm not going to introduce everybody first of all. I'm going to ask each presenter, when you're speaking, just to introduce yourself and your role, and very briefly where you work, if that's okay. Really great to see how many people we've got today. I think we've got 38 people in this call, and had a really quick look just before we got started, and it's great as well to see such a variety of roles. So we've got clinicians, we've got people who work in the third sector, we've got people who work directly with older people and people who are living with frailty. I think we've got some ambulance crew, so really, really positive that this was of interest to so many people. So just checking, we've muted everybody as well. Just a reminder to each of the speakers as you start talking to unmute yourself, and if you're not talking, just to pop yourself on mute so we can limit the feedback as well. Just to let people know then, today we'll be covering frailty. So this will include the Leeds Vision for frailty. We'll be looking at services and programmes that we've got in Leeds to address some of the issues for people living with frailty. We'll be looking at how we can collectively understand frailty, its impact. We'll have a presentation on some of the work around personalised care and what matters to me. We'll be hearing directly from one of our third sector services who support people living with frailty, and then we can talk through some other training opportunities and resources for you, your colleagues, and your services as well around that. There is a little bit of feedback, so I'm going to turn myself onto mute. I will come back a little bit later. My name is Rachel, I work in public health and I work in the older people's team. I think our next slide, I think I'm handing over to Emma, who is going to talk about the vision and an overarching introduction to frailty.
Hello, thank you ever so much. My name is Emma Heason. I'm the Frailty Programme Manager working for NHS Leeds CCG. So my first slide today is what is frailty? Which is a bit of an obvious question, isn't it? But it's not always an obvious answer. So frailty is a term that we all use a lot, but a lot of us don't always understand what we're meaning when we use it. When you use it properly, it talks about a person's mental and physical health and resilience, or their ability to bounce back and recover from events like illness or injury. It doesn't mean that if somebody is living with frailty that they lack capacity or indeed incapable of living a full and independent life. And that's what makes it so critical that people living with frailty have access to really well planned and really well joined up and coordinated care in order to help people prevent problems arising in the first place. If we get better as a community of healthcare and third sector people working together, if we get better at delivering proactive care as a system, we'll inevitably recognise changes in people's health and well-being much, much faster. We can then support people living with frailty to make better contingency plans and manage their health conditions, thus avoiding some of the unplanned hospital admissions, which cause people so much difficulty when they have become admitted, when they result usually from things like a crisis, such as a fall. Frailty can increase and decrease during a person's life, and it depends upon other factors. So, for example, if you have a fall resulting in an injury, or perhaps even an illness such as cancer, which causes a deterioration. And at the moment, particularly with COVID, we've got terrible issues, haven't we, around grief and isolation and loneliness. And there are other things such as malnutrition and dehydration, which play a major part in people's general state of health. Some of these things contribute to increasing frailty, can also improve over time, which is the good news. If we get better identifying frailty earlier, we'll recognise periods of decline much quicker, and then we have a greater chance of supporting people to plan their best possible experience as they approach their end of life. So one of Leeds' greatest assets is the passion with which our healthcare and third sector partners deliver what matters most to people living with frailty. Many of you will recognise Dr. Eileen Burns, and she's provided a determined and passionate voice for Leeds over several decades, heralding the importance of delivering care that is joined up, as I've already described. She was actually awarded an MBE for her services to integrated care for older people, so she's a great ambassador for Leeds. And she's an advocate of prevention and telling us all how much we can make ourselves much healthier and have healthier lifestyle choices, which potentially could change our outcomes going forward and the level of frailty that we may all end up with. One of our biggest challenges at present is social disengagement, as I've already said, through COVID. And that's something that we really need to bear in mind going forward about how we reintegrate our community and try to support people living with frailty to live a much more well-rounded life. Some of you will have heard of the Frailty Fulcrum, many of you won't. It's a recognised model that identifies a common language that we can share between individuals, family carers and professionals to increase recognition and understanding of frailty-related issues that affect a person's general quality of life. When we go onto the screen in a minute, you'll see that it depicts a seesaw with a central point, which is the fulcrum, which acts as a balance for our activity and our events in life and situations that we would all have as a person living with frailty. And it'll show that frailty is dynamic and fluctuating, as I've already described, and it's dependent upon the influence of external factors such as environment, injury, infection and experience. In order to achieve the right balance between vulnerability and resilience, a person must achieve a balance of factors that makes us whole.
Here's a young person. When we're young, we're resilient. We're energetic and carefree. And when we need to push ourselves, we don't think twice about it. As time goes on, we begin to change. Life isn't quite as straightforward as it used to be. And the things we used to be able to do, we can't always do in the same ways. By the time we reach older age, we have to start being more careful. It's not that our quality of life is diminished, we just have to be aware that some things become more difficult, and the likelihood of a small thing causing a big problem is greater. There are many different aspects of our lives that contribute to our well-being. We will call these domains. Things like our social environment. This can be our families, our friends, our communities, any of the people or places that are important to us. There's also our physical environment, particularly our homes, but also the many places we visit as we live our lives. We also have our psychological status, made up both of specific conditions such as anxiety or depression, or more general feelings like a loss of confidence or a lack of motivation. Many of us are also living with one or more long-term conditions. Things like diabetes, heart disease, arthritis, or dementia. Inevitably, from time to time, we will also encounter acute health problems. For example, things like infections or injuries. Finally, we have the systems of care that exist to support us in our times of need. They have a direct impact upon our well-being, not just through the care they provide, but also through the way they deliver that care. Our quality of life depends on the balance and interactions between these various domains. Domains that have a bigger impact upon our quality of life are further from the centre. The position of these domains comes from understanding how each one is affecting us as an individual. If they are putting our quality of life at risk, they create vulnerability and are placed to one side. However, if they are reducing this risk, they are adding resilience and are placed to the other. Our quality of life depends upon the overall balance between this vulnerability and resilience. Over time, the positions of these domains may change. Sometimes this will be because of something we've done ourselves, and sometimes it will be due to outside influences. When the influence of one domain changes, quality of life can be maintained as long as the overall balance between vulnerability and resilience is preserved. This can be done either by addressing the issue in that domain or by offsetting it with actions in another. Therefore, regardless of the specific impact of any one domain, we can always help to achieve the best possible quality of life by considering the others. The difficulty in balancing all domains is the condition called frailty. Now we can understand why keeping a good balance between all the different things going on in our lives becomes more difficult as we get older. Impacts that might cause a loss of balance in someone who is frail do not have the same effect on someone who is not. This model shows the relationship and difference between frailty and ageing. It also shows the dynamic and holistic nature of frailty and its direct relationship to quality of life. Perhaps most importantly of all, this model makes us realise that many different opportunities exist to help achieve the best possible quality of life for people with frailty.
Okay, so this is my version of the Leeds Proactive Frailty model. I've tried to make it really simple and recognisable for us across healthcare and third sector partners. And as you'll see, hopefully from the picture, we're trying to place people living with frailty at the heart of everything we do. It reminds us to ask what matters to people and support them to achieve personal choice and an increased quality of life. In Leeds, we're really starting to embed a what matters to me kind of approach, comprising 5 simple questions that consistently check in with people to help them to identify the most important people, the activities, their ambitions, and certain behaviours that individuals would wish to keep at the forefront when receiving healthcare and third sector interventions. The model really recognises the importance of family and family carers as partners in a person's care and for supporting people to live a fulfilling life, even when frailty increases personal challenge. And talks a lot about effective social connectivity helps people to maintain balance, as previously described in the Frailty Fulcrum. It's also recommending that we build and strengthen our multi-skilled teams to wrap around the needs of the person and anticipate and plan for crisis where possible. But in the event a crisis does occur, it pledges to respond in a timely way, offering credible alternatives to hospital admission. It advises us to promote a home-first approach, irrespective of where a person lives, such as their own home, supported living, or in a care home. And it tells us to use the Leeds data model, which we're really lucky to have, which helps us to identify population health information at geographical place level and supports us to proactively target people with the most alarming health inequalities, which regularly impact people living with frailty. So, for example, the age at which frailty or decline occurs, and even life expectancy because of where people live, their ethnicity and their lifestyle choices can really differ, and up to around a decade between some areas. The model also urges us to agree a shared language and cultural systems to describe how we talk to and about people living with frailty, making it easier for everyone to understand what is needed. And ultimately, it describes our ambition to develop a truly integrated Leeds system, Team Leeds, as you'll probably hear it called, that focuses on local people in local communities with very individualised care and support needs. So what can we do to prevent frailty? We already know that we can slow it down. So what are the things that we might do? This slide provides a summary of the things that we possibly could do to support ourselves to lessen the impact of frailty on ourselves and others. And recognising frailty earlier, as I've already said, in a person's journey provides more opportunity to slow decline and for us to make contingency plans and preventing crisis. And supporting people to develop self-management techniques enables people to recognise changes in their own condition and offers a chance to enact contingency plans, potentially avoiding unplanned crisis, hospitalisation and generally poorer outcomes for people. There are so many things we can do to lessen the impact of frailty, and the things on the screen are just a few. Thank you. I think I'm going to hand over to Jesslyn and Lydia.
Thank you, Emma. I think I'm going to have to leave at some point, so if anybody does have any questions, we can keep hold of those and we can have a chat with Emma afterwards. So thank you for that. And as Emma said, we'll hand over to Lydia and Jesslyn to talk about personalised care and what matters to me.
Thank you, Emma Rachel. Thanks to everybody who's joined today. I'm Lydia Robson. I'm a health improvement specialist in the personalised care team here at Leeds City Council. So I'll be providing a brief overview of personalised care, the work around what matters to me and what this means for Leeds, as well as how this relates to addressing health inequalities in frailty. So what is personalised care? Personalised care means people having more choice and control over the way that their care is planned and delivered. This involves placing the person at the centre of their care, really providing care that's tailored to what matters to individuals in the context of their whole life. So personalised care is also important in terms of addressing health inequalities, especially in terms of frailty. So evidence shows that populations experiencing inequalities are more likely to experience premature frailty, and those with the greatest need often have the greatest difficulty in accessing and receiving the appropriate care and support that they need. We know that 1 million people over the age of 65 report being lonely, social isolation affecting people of all ages. So we know that it leads to poorer health, higher use of medication, increased falls and increased use of GP services. So frailty in older age is also associated with a heightened risk of disability, falls, admission to hospital and mortality. So whilst the biological mechanisms of frailty are increasingly understood, relationships with the wider determinants of health and health inequalities and resilience are less well established. So evidence shows that the wider determinants of health accelerate the development and progression of frailty, driving health inequalities in later life. So in line with personalised care principles, it's therefore important that we don't widen any health inequalities. And by understanding what matters to the person, people can be signposted to appropriate services and receive the right care for them. So with this, people are seen as equal partners, with patients being experts in their experiences and knowing what's best for their circumstances, as well as the role of professionals as well, bringing their own expertise and knowledge. So this means a shift in relationship between health and care professionals and people, switching away from the what's the matter with you approach to what matters to you, and moving away from doing things to people and working with instead. So personalised care also means a shift from a purely medical model of care towards a biopsychosocial model and really looking at the social determinants of health. So this means that when people are in our care, we should look at their physical, mental and social well-being and appreciate how these all interconnect. So it's about a whole system approach, integrating various services, including community-based support and wider services around that person. So at its heart, personalised care is about working with people and focusing on what matters to them, putting people at the centre of their health and care and enabling them to be active participants in health decisions. So as outlined in the picture here on this slide, what matters to me is the foundation for a collaborative and better conversation. And understanding what matters to the person, their preferences and needs enables us to really get to know the person in the context of their whole life and therefore provide the best care and achieve better health outcomes. So in Leeds, we've developed 5 questions to facilitate better conversations with people. So having this conversation puts us in a much better position to be an effective partner in supporting people's health and care. So Emma touched upon this earlier. Our ambition is that everybody has this what matters to me conversation. So we're working to make sure that people and professionals are able to record this in a person's health record so that this can be shared across systems. So the 5 questions around what matters to me are, firstly, asking what matters to me. So this could include meaningful activities such as leisure, visiting places, employment, education, volunteering. You could also talk about the values that people hold. Secondly, who are the important people in my life? So this could include any support network people may have, family members, carers and friends, and why they're important to that person in managing their health and care. Thirdly, what things do I do to keep well? So this could include strengths and skills, how people engage with others and how you feel on a typical day. Fourthly, key things to think about for my future. So this could include goals and aspirations, could also include how and when to support the person, understanding dangers and risks, support with important routines, and in terms of taking medications, for example. And finally, please do and please don't. So please do could involve any preferences the person has around their health and care. So it could be a reminder to take medication, or explaining to the person what's happening and why and what to expect next. And please don't could include not asking questions about certain topics or making assumptions about something and providing support when it's perhaps not wanted. So these are guiding questions to help you know more about the person and help approach the conversation. It doesn't have to be medical, as what matters to the person could be about them wanting to walk to the shop or be able to play with their grandchildren, for example. But knowing this and understanding this helps us to tailor the support that we can offer and together make a decision on how that can be achieved. One of the examples of where these questions are being used is within annual health reviews in primary care, including annual reviews for Frailty. So by doing this, we can better support people to live healthy and fulfilling lives. Thank you.
Thank you, Lydia. I'm going to move on to talking about one of our services that we have in the third sector to support people living with frailty. So I'm quite aware we've got some people on the call who will know this service very well and who deliver this service, and there may be people who haven't heard of this service. So I'll just give a 5-minute overview. So the service I'm talking about, we call SWIFT. That stands for Supporting Wellbeing and Independence in Frailty. So in Leeds, we've got 11 different organisations who provide this service. The service is citywide, but we do have organisations who deliver in a locality because we feel that they bring the expertise of knowing that area and what's available and suitable to support somebody in their local area. So our SWIFT service basically provides a holistic assessment of what matters to somebody living with frailty. A one-to-one conversation can include identifying somebody's strengths and their resilience factors, and also understanding what they may want to achieve, what goals they may want to have, and what barriers they're currently facing to achieve those. So the SWIFT service takes a person-centred approach. So we have SWIFT workers who can work with somebody one-to-one pre-COVID in their home, post-COVID in lots of creative ways to identify things that they may wish to build on and identify things that they may wish to develop. Our SWIFT workers can offer practical support and practical solutions to help people build on their strengths. And the SWIFT service is really, really holistic, and it involves, we've got some evaluation that talks through all sorts of different sorts of interventions and support that people can be offered. And I guess from the presentation that Lydia's just given, and how somebody can identify what's important to them, kind of demonstrates the broad range and the complexities of some of the issues that people may be dealing with. So we do have 11 providers, but we do have a citywide provider. So our colleagues at Age UK Leeds can take referrals and can triage people into a local service. So I've just popped the details on the bottom of the slide there, and we can share the details of the local providers as well. So as I said, we've got 11 providers. The service is for people who are 50 or over living in Leeds who are living with frailty. We've just had an evaluation done. I'm not sure if people can quite see this, but just overarching, our evaluation has told us that just under 40% of people who are supported by SWIFT are living in our most deprived areas in Leeds. The service is supporting people from ethnic minority backgrounds and also are working with people who are lonelier at the start of their support than the general population. So we know we're working with people who need that support. The evaluation looked at the different interventions that were delivered, and we do a pre and a post intervention questionnaire to understand if we're making a difference to people. We've just had some results back that showed basically around 50% of people were actually seeing statistically significant improvements in their self-reported health and well-being, independence and loneliness. So an improvement in loneliness. They weren't getting lonelier. And given the context, given the fact that we're working in COVID, I think these results are fantastic and really, really demonstrate the impact that the SWIFT service can have for people. The interventions are really, really varied, and I'm going to pass on to some colleagues who are going to talk through some case studies in just a moment. They're really varied. They may be looking to support somebody who needs change in housing. They may look at supporting somebody who needs some advice around particular health concerns, whether that be strength and balance, nutrition. As I said, we look at wider determinants as well around housing. It may be that somebody needs some support to change their energy tariff. It may be that somebody would benefit from a referral or being signposted to a service, so in particular a mental health service. And I think as well some of the examples that we're going to see demonstrate that some people have some really, really complex issues with lots and lots of kind of facets to that, and there are lots and lots of areas of support that people need, and that our Swift workers can take somebody on that journey. Here we go. So I'm hoping I'm going to hand over to Donna, who's going to talk through an example of a case study of somebody who's been supported through the Swift service.
Brilliant, thanks. Hi everybody, my name is Donna Waldron. I work at Richmond Elderly Action, which we call ourselves RIA for short, as a Swift engagement officer. So Swift again is supporting wellbeing and independence for frailty. I've been working at RIA for just over a year now. I'm also a trained fitness instructor as well. So my case study today is Mr. P. He's age 60. He's had 3 heart attacks, back problem, bowel resection, asthma, COPD, recovered alcoholic, anxiety, depression, and dyslexic. His first language is actually Greek. He speaks English, French, and 5 different African languages. English is, though, about his 7th or 8th language. He was referred from Leeds Mencap to St Vincent's for food and help with finances, and to us at RIA for more long-term and ongoing support. It was March last year, during the first lockdown, that I received the referral from Mr. P. And the referral actually came through Voluntary Action Leeds to the Leeds Mencap, who then referred to ourselves at RIA and to St Vincent's. So what the referral said, he hadn't received any money since January 2020 and hadn't eaten for 3 days. He had no family or friends. His wife had moved back home to Greece. He had also asked for some support regarding his mental health and well-being. He'd been put on medication, asked for support for his depression and anxiety for the past year with no success. He's dyslexic and cannot read letters that come through the post, and English is not his first language. He had no washer or cooker as they broke. He asked a neighbour to help read a letter that came through the post. Mr. P believes she took his details and changed the delivery address of a new washer as he never received the goods. Another neighbour told him that the neighbour that had read his letters was selling a new washer. Okay, so Mr. P received a food parcel from St Vincent's. He then queued every day, long queues to get hot meals. He got 2 hot meals, 1 for lunch and 1 for tea. I phoned Mr. P regularly. He had a lot going on, and luckily with my Swift role, I could help him with no time limit. So ongoing, sort of like at first, I took most of a week basically trying to help with all the sort of issues that Mr. P did actually have. So through conversations, we established that Mr. P reading and talking in Greek language is a barrier. He could only read in Greek. People didn't give him the time to try and translate his words into English or find the right words to use. This was the most important thing to him. He needs to get his money sorted. He needed cooking and washing appliances. With his conditions, hand washing clothes was a struggle. He was only receiving food Monday to Friday, and as demand for food increased, St Vincent's eventually had to condense their days to 3 days a week. So from then on, us at RIA, we did actually start supporting him with some food parcels as well. His phone had got stolen and was unable to communicate with family or friends, and he had no one in England. Crime in the area that Mr. P lives is very high. I checked with St Vincent's regularly because I wanted to make sure everything was happening and, you know, things were getting sorted. So I wanted to know where they were up to with the finances, because they were supporting with that. They were waiting for Mr. P to receive a letter from Universal Credit, and he took any letters he received to St Vincent's. Weeks and weeks passed and there was no news of receiving any money. The person dealing was furloughed, and due to the COVID-19 lockdown, nothing was happening at all. So Mr. P was very stressed and informed me he had been threatened of being evicted from his home for not paying his rent, and I got in touch with his housing officer to update them. I tried ringing them myself, which was the welfare rights, to investigate his money not being paid. The queues on the phone were very long, and after queuing I got cut off. When I eventually got through, I was told that they couldn't speak with me as not my account, and that Mr. P would need to ring. Through the local care partnership meetings we attend, a contact name was established at DWP, so Department of Work and Pensions. I got in touch and kept communication until it was sorted. It was established that the claim had actually been closed in February 2020 last year, and it wasn't clear why it had happened. He had an assessment months earlier that should have been added to his new claim, and he was actually entitled to personal independence payment. And thanks to 2 employees at DWP, his money was sorted, and he got his monthly back payments and some back pay. Whilst the money problems were going on, I applied for the white goods at Welfare Support to try and get Mr P a washing machine and a cooker, but the service wasn't running due to the lockdown. I continued to ring and check it back operating. Eventually, just after his money was sorted, I was told they could get him only 1 appliance, as he's a single person. A cooker was delivered. So Mr P bought a washing machine out of his back pay, and he bought food of his choice and was very excited to be able to cook again with the new appliance received. He couldn't wait to tell me what he was going to cook. And he also bought himself some much needed footwear. From receiving the referral for Mr P, I got in touch with the Greek Orthodox, and a priest from Sheffield visited him and a phone befriender was set up. The priest also brought books in Greek for him to read. Mr P was able to talk and read comfortably in his first language, which was really important to him. Through conversations and the help and support of 100% Digital Leeds Libraries, an iPad was loaned from them, which had 4G and enabled Mr P to use the internet. With the help of an organisation called the Tech Ladder, they benefit underprivileged and unemployed people to improve their lives with education and technology. I was able to support him in getting set up on his device. I helped him set up and trained him on Facebook, Messenger and Skype. I showed him how to Google Translate and use Siri. Siri is basically, if anyone doesn't know, it's basically when you sort of talk into the microphone and it brings the words up. I also showed him how to change the language on the device so he could put into English for me to support him and change back to Greek for him. Having no phone with the help of the iPad, Mr P was able to type and send messages in Greek on Facebook and Messenger. He was reconnected with family and friends in Greece, Belgium and Africa, and he was especially thrilled to be reconnected with his son. I took the time needed to help train him, which did take a lot of time, but it was one of the most important things to him as well, to try and get that connection. It was really thrilled as well to send photos and see people in pictures on Facebook and Messenger. He was able to make phone calls and messages to family. Using Skype with me, he was able to have face-to-face meetings, and he could show me any letters received. He also used the iPad to attend church service on Sunday in Greece. Other support I gave him was due to the COVID-19 pandemic. Public Health issued the published guidelines in 12 different languages, but unfortunately Greek wasn't one of them. And I got in touch with Public Health Resource, and they were able to source some Greek literature from the World Health Organization. I contacted Later Life Training, who I've actually had evidence-based training with before, and inquired if I could get an exercise booklet in Greek. They contacted some associates in Greece, and a booklet I had in English and taught was found in Greek, so it was really good because I could understand what was in the booklet he had. I ran the doctor's surgery to explain when appointments needed. I also did a phone consultation with Mr P and the doctor. I found that consultations were not long enough to allow the time to translate and find the right words to explain, with English being the 7th or 8th language for Mr P. Something else to mention here is during the pandemic, many people did actually think the GPs were closed, so there was a lot of education was going on there to let people know that they were actually open. I supported a conversation with the police about the stolen phone that Mr P had, and had from us. Organised food parcels and short drinking every day when you get food. Luckily, a colleague's family did actually kindly donate a microwave, which was given this to Mr P. Other support I gave referred Mr P to Leeds Mental Wellbeing Service. The waiting list was absolutely massive. In the summer, I was told it was going to be February before I was seen. I did get a phone call to say that was the case. I also referred him to Lincoln Leeds and Swarthmore College as well. I supported when Mr P had rang for an ambulance. He had abdominal pain and breathing difficulties, and after 2 hours, an ambulance hadn't arrived. So he actually rang me to let me know he'd done that. I rang, and 15 minutes later, the emergency service did actually arrive for him. Sadly, the actual iPad that he'd actually got loaned did actually get stolen as well. I supported him to communicate with the police. It was really, really low because he lost connection with his family and friends in the country because he has nobody in the UK. He did have a phone at this point, but struggled. It was very, very small to see and navigate on the internet. So I contacted 100% Digital again to report the theft of the iPad. They had actually had some donated tablets with 20 gigabyte of data with a small Wi-Fi box, which is like a separate thing to connect to the internet, like a little mobile sort of Wi-Fi box. I was put in touch with the gent who delivered the device to Mr. P, so we're lucky to actually get another device which was donated for him to keep. So Mr. P now, he communicates with family and friends by phone and social media, so like Facebook Messenger and WhatsApp. He watches movies and listens to music on the internet. He rings to make appointments or rings organisations with queries himself. He searches the internet for information he wants to find out about. He attends the online Greek church services still. He reads in Greek, his first language, which makes him comfortable to read. Goes shopping himself, enjoys cooking meals again. He exercises at home. He used the booklet I got him and a resistance band I gave him as well. And he walks every day. He's still in contact with the befriender from the Greek Orthodox. And since writing this case study, as I say, he's now attending Swarthmore College and he wants to get a job in computer skills. But the support doesn't end here. There is always something else that still pops up. And he's got other problems coming up now, debts that come from up, and then problems with neighbours. There's always going to be something else popping up. Here we just had some feedback from Mr. P. He says, I thank you from the bottom of my heart. I'm excited to get a cooker, he said when he got his cooker. My first meal will be lamb and then aubergines. I'm happy to find my family on Facebook. I'm so happy to be back in touch with my son. Thank you, thank you, thank you. So that's Mr. P's case study. Thank you for listening. I'll hand you back over to Hannah.
I'll just jump in if that's okay. Just to say thank you, Donna. That was a really, really detailed case study, and I think it kind of sums up some of the things that we've just talked through, that basically talk about what's important to somebody, and some of those outcomes that you've talked about and how they impact on frailty are a massive achievement and demonstrate kind of the scope that we can have with Swift, and also the very complex lives people live, and the variety of different interventions and support that the Swift service can offer. So please do, I can send some information afterwards, but if you can think of people that you're working with who can benefit from the Swift service, there is capacity in the service to support new people across the city. We also do have a little bit of extra capacity to support people from culturally diverse backgrounds, and there is a little bit of extra support through Age UK Leeds for people living with frailty who may have more complex mental health problems as well. So please do get in touch if there's anybody that you're working with who could benefit from that service. But Donna, the perfect example of the broad range of the service that can be offered. So I'll hand over to Hannah now.
Thank you. So we're coming to the end of the slide deck that we've got for this webinar, and we just wanted to give you a bit more information about where to go for information. So the Public Health Resource Centre is something that Donna just mentioned in her case study there about getting in touch with them to find more translated materials. The Resource Centre is open to anyone in Leeds who has an interest in public health or promoting health and well-being. And they have a whole ton of free resources. So if you go to the website there, they've got leaflets, they've got books if you're looking for a bit more information on something. They also have a whole host of games that you can play with people to kind of promote health and well-being. But they also have more of these want to know more sessions. So it's a brilliant resource, lots of free information. And if there's something that you can't find that you're looking for, if you get in touch with the team as well, they're very friendly and will be able to help out with that. And then the second one that we've got on there, you may have heard of them already, but the Leeds directory was revamped in the last few years. So if you haven't been to the new website, go check it out. They, again, are really good at kind of connecting people to local services, as well as local activities and events. They also have an information and advice section, and kind of quite a lot of information to support people in their local communities, if that's something that you're working with someone on. There's the website on there, and then if you go to that, there's also a phone number. So if somebody isn't digitally connected, you can give them that phone number and they can call up and speak to a member of the team rather than having to navigate their way through the website. So if you're interested in frailty in Leeds and you want a bit more training, there is a short online training that's the top one there about how to identify frailty. This is quite interesting. I quite liked this training. You don't have to be someone who is identifying frailty in your work. It kind of talks through the real life scenarios of frailty and kind of what that looks like for different people. So it's not clinical. It's more about how people live their lives. So there's the link there, and we can send it out with the slides as well. So if that's of interest to people, you can get a little certificate at the end. It takes less than half an hour. And then Emma Heeson, who was speaking at the start of this session as well, has been developing some frailty training as part of the Leeds Frailty Partnership. There will be some modules that are aimed at the specialist workforce, and then some aimed at the wider health and social care workforce as well. So that should be due to launch in autumn, and we can keep people up to date with that as well, if that's something of interest to people. This is the one that the Public Health Resource Centre has given us to inform you all of. If you'd like a copy of today's slides, if you email that email address there, rather than us spamming you with slides if you don't want them. So if you email Public Health for All at leeds.gov.uk, the recorded session of this will be edited nicely and then also put on the YouTube playlist as well. And there's the shortened link there for you to have a look. And then there will be an electronic evaluation survey sent out. If you wouldn't mind filling that in, that would massively help us. Thank you. And again, there we've just got the links for the Public Health Resource Centre. And then I think now we've got a bit of time. We finished a bit early, so I think we've got time for a Q&A session.
We have. Thank you to all of our speakers. If people would like to use the chat function, if you have any questions or comments, then please do. We'll give people a minute or two. We had, I've not seen any questions. I wonder if everyone has just found everything that they were hoping to. Okay, it doesn't look like we have any questions. So we will say we got through that nice and quickly. Thank you so much for joining us. Like I say, it was great to see so many people here. And if you do have any questions, we'll be able to answer those if you contact Public Health for All. Hopefully people have found that useful and enjoyed the session. And I think we will close it there. It doesn't look like anyone's got any questions. So thank you for joining us and enjoy the rest of your day.